And now I think I am forced to, and he gave me something which is not the usual talk or usual topic covered in a general medical CME, hypertrophic cardiomyopathy. so I don't want to bore you much. A high protein, high fiber diet is, lunch is awaiting all of you. So please sit back and relax and get whatever little bit about hypertrophic cardiomyopathy from this. You can take that. Now, this is a case report of a 32-year-old software engineer who had breathlessness on effort to 2 to 3 years, but the past 3 months it has worsened. He gets palpitations during breathlessness and no orthogonopy of P&D, but he has noted chest discomfort on the left side of the chest on effort and occasionally at rest, and sometimes the chest discomfort lasts longer. His examination findings were not very thin, but JP not elevated, blood pressure was normal, pulse normal. Apex beat actually showed a heaving apex beat with a loud S4, and there was a grade 3 ejection systolic murmur in the left sternal border with no radiation to the neck or axilla. And the murmur appeared to increase with Valsalva and on standing posture and decreases in intensity of our hand grip. Other systems were normal, and this was the ECG, which showed evidence of the repolarization changes in the form of T-wave inversion extensively in lead 1 AVL and precordial leads, and Q waves in leads, inferior leads 2, 3 AVF, and prominent voltages in the mid-procordial. And an echocardiogram showed the typical feature of hypertrophic cardiomyopathy. The septum, the interventricular septum, is thickened, and the thickness diameter is 20 millimeter, and it can be measured in the M mode. And it also showed what is known as the systolic anterior movement of the mitral valve, where during systole, anterior mitral leaflet actually move forward. You can see the arrow touching the interventricular septum. This is a SAM, or systolic anterior movement, and that is also seen in this M mode, and it produces sometimes a mitral regurgitation as well. So this is hypertrophic cardiomyopathy, the classical features, symptoms, the physical signs, and supported by the electrocardiogram and ECG. And actually hypertrophic cardiomyopathy is the most common genetic cardiovascular disease. It is caused by mutations in the gene, but the phenotypic expression actually varies. And it's the most common cause of sudden death. Previously it was called, when in the olden days, the idiopathic hypertrophic subaortic stenosis and asymmetric septal hypertrophy, but all these terms are replaced now. There are two broad groups, obstructive and non-obstructive. And obstructive is where there is a pressure gradient between the LV outflow tract and aorta, and non-obstructive is where there is no obstruction to the LV outflow. But the obstruction in hypertrophic cardiomyopathy is not fixed, it is a dynamic. It is the spontaneous variability from day to day, and it is also influenced by factors like myocardial contractility and loading conditions. Now, then there is some variance. We can see all the time the mid-cavity obstructive hypertrophic cardiomyopathy. Instead of the left ventricle outflow, the obstruction occurs in the middle of the left ventricle because of the abnormal position of the papillary muscle and how it is attached to the septum. Then another variant is called the apical hypertrophic cardiomyopathy. It has a regional variation where the hypertrophy is not predominant in the septum, it is confined to the apex, predominantly in the apex. And this variety actually is fairly common in India and in Asia. And I think this is, I think all of you must have seen patients coming out with this giant T-wave inversion. ECG is frightening, but the patient is totally asymptomatic. They may come to you, and inadvertently most of these patients end up doing a coronary angiogram because the T-wave inversion in this entity is very, very frightening, very giant TV invasion, so that invariably you think about an acute coronary syndrome and they'll end up with acute in the ICU. So I used to tell my patients with apical hypertrophic cardiomyopathy, because it is relatively benign, even though it has some morbidity as well, to keep a printed copy of the ECG with you and say the diagnosis of apical hypertrophic cardiomyopathy there printed, so that you can avoid unnecessary procedures and unnecessary intervention. Then you have another variant where there is a right ventricular outflow obstruction, and there is an entity called obstructive hypertrophic cardiomyopathy in the elderly, where it is a milder hypertrophy. The septum is elliptoid shape and probably has less long-term complications. Now we have told about dynamic LV outflow obstruction. Sometimes the LV outflow obstruction may not be apparent initially, may be normal, but then you have to provoke it. And there are methods. You can do an exercise echocardiography, and during exercise you can provoke the gradient. And pharmacological agents, dobutamine can be used, Valsalva can be used, and there is no predictable correlation between the LV outflow tract gradient and the symptoms. Now the pathophysiology, I don't want to go into detail. It is systolic anterior movement, abnormal position of the mitral valve, everything. But genetics of familial hypertrophic cardiomyopathy now has been well established. So many mutations in the sarcomere, the contractile protein of the heart, and different, now there are genetic tests are available to that. Now it is fairly common disease actually, 0.5%. Overall prevalence can be variable. Sometimes in a cardiology population, I think you may see 1 in 100 or so. And 25% of the first degree relatives have hypertrophic cardiomyopathy. It's more common, slightly more common than male, female, or the inheritance is autosomal dominant. But usual age of presentation is at the age of the third decade. And any age can occur. It can occur when infancy and children. At that time, if it occurs in the infant and children, it is a slightly worse prognosis, and it can happen maybe in the second decade. And this is the pathology. And the ultimate pathology is three things. One is the hypertrophy of the individual myocyte. Secondly, the disarray, the organization is not smoothly arranged. And thirdly, interstitial fibrosis. Between there is a fibrosis. So this is the pathology. And there is, along with that, there is a abnormality in the microvessels, the reduced vascular reserve, leading to microvascular dysfunction in angina. Chest pain is another feature of hypertrophic cardiomyopathy. It can be either mimic closely a typical angina or could be atypical. Angina usually precipitated by this chest pain is precipitated by heavy meals, and the reasons are then arrhythmia are very common. Both supraventricular and ventricular arrhythmias are common, and the patients have palpitations and tendency for sudden death. Syncope is a very, very common symptom, not a very 15 to 20% of patients with hypertrophic cardiomyopathy report at least one episode. And multiple mechanisms, it could be a simple vasovagal attack, it could be an arrhythmia, atrial fibrillation, ventricular arrhythmia, it could be dangerous and fatal, but it could be, may not have a significant prognosis also, but needs to be evaluated. Physical examination, we all know, we just said that, forced heart sound murmur, and the systolic murmur, dynamic, we all learned in our general medicine cardiology examination. Murmur is a crescendo, decrescendo murmur, but it increases in intensity in upright posture from squatting. So if you ask the patient to stand up from squatting position, the murmur increases because the venous return decreases, the LV volume comes down, and the LV outflow tract obstruction increases. So intensity goes out. Valsalva. Then after a ventricular ectopic, all these maneuvers will bring out the murmur. And the things which decreases the murmur are sitting from standing position. So you auscultate on standing and ask the patient to sit the murmur will come down. Then hand grip, it will come down. And simply elevating the leg, the murmur will come down. And other things we don't want to. So the diagnostic evaluation, that is the basically consists of the echo and the ECG echo, and we have already discussed about this. ECG, we have already told you. The echo, there are features which clarify that it is hypertrophic cardiomyopathy is the thickness of the interventricular septum. It can be anywhere, but anywhere in the left ventricle, if you find a thickness more than 15 millimeter, and there is no other cause for hypertrophy, it is diagnostic of hypertrophic cardiomyopathy. Between 13 and 15, you have to be suspicious, and it's a borderline. But if its thickness is only normally is up to 11 millimeter, so it is 12 or 13, it is not likely to be hypertrophic cardiomyopathy. It can be used localized. Then some and other findings you can find from the echo. The left atrial size is also important. In all patients diagnosed with hypertrophic cardiomyopathy, you should have an ambulatory ECG monitoring, because these people are prone for ventricular arrhythmia, and that is also prognostic information. So an ECG monitoring should be done. An exercise testing should be done, preferably with an imaging. That is to find out his functional capacity, as well as to bring out the LV outflow gradient if there is no gradient. And of late, cardiac MR has come out in a very big way, because it can, when echo is not very clear, where the measurements are not very clear, cardiac MR will give you the accurate measurement of the wall thickness. And sometimes the thickness is not in the septum, but in some other parts of the left ventricle. It could be very localized, and you can easily miss the hypertrophy. And then cardiac MR will come. Secondly, the late gadolinium enhancement, LGE, indicate fibrosis of the myocardium, which is a part of hypertrophic cardiomyopathy. So CMR, if you are in doubt about the diagnosis, send the patient for cardiac MR. The genetic testing routinely is not recommended, but if you have a patient and if the relatives you suspect they have a hypertrophic cardiomyopathy, after examination, you can send them for a genetic testing. Catheterization is usually not required much. Differential diagnosis, you should rule out the degenerative disease, glycogen storage disease, Fabry disease. They are not, but some people say that Fabry disease is not as uncommon as we thought. Hypertension and aortic stenosis, but this condition, athlete's heart, we have to consider in our differential diagnosis, because a lot of people like Vaibhav and Manikandan, who does the strength exercise, may have left ventricular hypertrophy. The one feature to distinguish is usually the LVH is not 15 millimeter, usually only 13 or 14 millimeter. The second point is the LV cavity size. In athletes with athletic heart, the LV cavity is larger, but in hypertrophic cardiomyopathy, LV is small. So that can be used as a distinctive feature. Coming back to our patient, the echo showed LA dilatation, ejection fraction was normal, SAM was present, the gradient was 54 millimeter, RV function was normal, CMR was not done, but ambulatory ECG shows VPCs and couplet, but no episodes of ventricular tachycardia. He was put on metoprolol 25 milligram once daily, and he was encouraged to do regular walking. But then his family background was checked. What happened was he is 32, he has a brother who is 28 years asymptomatic. His father has hypertrophic cardiomyopathy, that was proven. One of the uncles has that. And there is a story of one great grandfather dying suddenly at the age of 49. So that is the history. 12 months later, he experienced an episode of syncope. It happened after getting out of the bed. It was associated with some dizziness. And repeat echo this time showed that increase in left ventricular hypertrophy. The diameter, diastolic diameter of the thickness septum was 24 millimeter. And then an ICD implantation was done, and he is doing well now. So one important part of hypertrophic cardiomyopathy is to evaluate for sudden cardiac death. The annual incidence is 1%, But I think it's very painful when you do lose a patient with hypertrophic cardiomyopathy who is on treatment, dying suddenly. But there are something you can think about, some risk factors. And these are the known risk factors for sudden cardiac death. If you have only any one of these risk factors, you should send the patient for primary prevention of sudden cardiac death by use of an ICD. Prior cardiac arrest, of course, family history of first degree or close relative less than 50 with SCD, recent syncope, massive LVH more than 30 millimeter, LV apical aneurysm, then end-stage hypertrophic cardiomyopathy with the ejection fraction less than 50%. Then there are risk modifiers like late gadolinium scanning, then burst of NSVT in ambulatory ECG. All these are factors favor. So if any one of them are present, in this patient which we have just said, there is a family, one relative with less than 50 years, he should have been recommended an ICD at that point. Anyway, now his LVH has increased and he has an ICD now. No, there is now a SCD risk calculator available, a computerized calculator considering all these factors, and the current guidelines recommend ICD in patients with one or more risk factor. Natural history, generally it is not a very high. Annual mortality is only 1 to 3%, and the prognosis has improved over the past 4 years. Now complication I don't want to. LVH generally once the thickness reaches the maximum level in the third decade, it doesn't progress much as you become older. Okay. The treatment part, I think I don't want to discuss the treatment part in this talk. But generally to the physicians, the only thing which you can say is improve hydration. Because as you know, if the fluid intake is low, the LV volume comes down and LV outflow tract improves. So treat the fever promptly, treat dehydration properly, treat fever also properly. Then avoid these drugs, the commonly used drugs, nifedipine, amlodipine, nitroglycerin, and vasodilator, even ACE-ARB, caution, digoxin, caution, furosemide, caution. So all the patients, when you are seeing this patient with hypertrophic cardiomyopathy in your practice, avoid these medicines. And specific therapy, I don't want to, beta blocker and calcium channel blocker, and now a new drug, mavacamten, I don't want to talk about this. So to summarize, it is a genetic disease, it is a disorganized myocardial architecture, many patients are asymptomatic, some have dyspnea, chest pain, syncope. And the evaluation, you can make a thorough evaluation by the ECG and echo, and genetic studies may be helpful. Risk stratification is important, and some patients may require ICD implantation. Thank you.
Thank you, sir. It was an extensive description about HCM and how to manage the patient. So if this patient, the index patient, suppose has 2 children, one male and one girl is there, what advice we will give for them? What will be the screening strategy for them? How long we have to screen them?
The patient which we have talked to 2 children. Now, I think routine genetic studies sometimes are confusing because they are not recommending, even if you have a genetic mutation, it may not be the same mutation of the patient. So, we don't recommend routine genetic studies. What we can recommend this patient is a simple electrocardiogram and an echocardiogram. And if they have no morphological features, maybe you can do this once in 5 years for the children. That is all you require.
Is there a role for cardiac MRI in such patients who
no,
don't have...
in the children...
Yes, ECG, echo, everything is normal?
Normal, no role for cardiac MR in this patient.
Thank you.
I think the recommendations also for family screening, they suggest up to 18 to 20 years they will be followed up. And if beyond 20 years development of
usually they occur in the third decade.
Correct.
So if it don't occur in third decade, still it can occur, but very, very unusual.
Very often we detect it during pre-operative evaluation. Patients are sent to physician or cardiologist prior to a non-cardiac surgery or some procedure. At that time, what will be the
Usual, I mean, this is very important area, but you have to assess the, I think it is better to do an exercise stress test and also echocardiogram about the extent of the gradient, the symptom status, history, sudden death, all this. If this normal is, functional status is normal, I think hypertrophic cardiomyopathy as such should not be a contraindication for anesthesia and non-cardiac surgery.
Sir, since the thickness of LV is a marker of mortality, will the septal reduction surgeries, either by surgery or alcohol septal, will...
septal reduction therapy has been shown to improve mortality in small studies. They are only very, very small studies, so we still don't know whether they have, and center to center, because the experience is small, and center to center experience also, so probably, but usually septal reduction therapy is done when beta blocker has failed, the non-dihydropirin calcium channel blockers have failed, in that patient who is severely symptomatic. So we don't know whether there is any patient who are not given, and it is not easy to randomize and see whether there is any mortality difference with the septal reduction treatment. But there is a preliminary data saying that there is an improvement in the survival.
Thank you, sir. Any questions from the floor?
ICD.
Device, yes.
I think I have lost a patient because the knowledge about the indication for ICD is slowly emerging. But 20 years ago, I lost a patient who was evaluated everywhere. Srichitra also, everywhere it is evaluated. Actually, now the current guidelines, according to the current line, he should have received an ICD. He had a septal thickness of 30 millimeter. He was only 25, working as a software engineer. And his brother also has hypertrophic cardiomyopathy. No family history of sudden cardiac death. But no CMR was done. I think at that time CMR was not available. He had LV outflow obstruction and he died suddenly. So I think all this, the septal thickness, the family history of sudden death in any member of the family, and non-sustained ventricular tachycardia in 72-hour ambulatory ECG monitoring, all this should be pointers, and you should recommend ICD. In this patient, we could have saved life if I had recommended ICD.